Gallstones, cholelithiasis, key points. Prevalence and epidemiology. 1. Commonality. Gallstones are the most common biliary pathology, affecting 10-15% of the population in Western societies. 2. Asymptomatic cases. Over 80% of gallstones are asymptomatic, with only 1-2% annually developing symptoms requiring surgery. 3. Geographic variation. A. In the USA and Europe, 80% are cholesterol or mixed stones. B. In Asia, 80% are pigment stones. Types of gallstones. 1. Cholesterol stones. A. Contain 50-99% cholesterol. B. Formed when bile is supersaturated with cholesterol or bile acids are low. C. Factors: obesity, high-calorie diet, oral contraceptives, and ileal disease resection. 2. Pigment stones. Less than 30% cholesterol. Black pigment stones. Common in cirrhosis and hemolytic conditions, example, hereditary spherocytosis, sickle cell disease. Brown pigment stones. Formed in bile ducts due to stasis or infections. 3. Mixed stones, contain both cholesterol and calcium salts. Pathogenesis. 1. Formation is influenced by supersaturation of bile with cholesterol. Gallbladder dysfunction, example, impaired emptying, mucosal factors. Infections, e.g., bacterial deconjugation of bilirubin. 2. Key step: cholesterol nucleation and crystal aggregation. Clinical presentation. 1. Asymptomatic gallstones. Typically detected incidentally during imaging. Prophylactic cholecystectomy is not usually recommended unless specific risk factors are present. 2. Symptomatic gallstones. Right upper quadrant or epigastric pain, often severe and lasting hours. Pain may radiate to the back and is frequently associated with nausea, vomiting. Symptoms may be intermittent and recurring. Fever suggests progression to acute cholecystitis. 3. Complications. Acute or chronic cholecystitis. Jaundice, if common bile duct is obstructed. Gallstone ileus, large stone eroding into the bowel. Empyema or perforation of the gallbladder. Diagnosis. 1. Clinical signs. Murphy's sign, tenderness exacerbated by inspiration during palpation. Right upper quadrant pain or palpable mass. 2. Laboratory tests. Indicators: fever, elevated WBC, and CRP. 3. Imaging. Ultrasound, USG first-line investigation. Magnetic resonance cholangiopancreatography, MRCP, to rule out cholelithiasis if jaundice or abnormal liver enzymes are present. Tokyo Consensus Guidelines Diagnostic Criteria for acute cholecystitis. A. Local signs of inflammation, etc. 1. Murphy's sign. 2. Right upper quadrant pain, tenderness, mass. B. Systemic signs of inflammation, etc. 1. Fever. 2. Elevated CRP. 3. Elevated WBC count. C. Imaging findings. Imaging findings characteristic of acute cholecystitis. Suspected diagnosis: 1 item in A plus 1 item in B. Definite diagnosis: 1 item in A plus 1 item in B plus C. Management. 1. Asymptomatic gallstones. Intervention required only if specific risk factors exist. large stones, greater than 3 centimeters, polyps, greater than 1 centimeter, high malignancy risk, porcelain gallbladder, or associated conditions, example chronic hemolysis, planned bariatric surgery. 2. Symptomatic gallstones. Cholecystectomy. Definitive treatment. Early surgery, within 5 to 7 days, is preferred for acute cholecystitis when feasible. Delayed surgery, after 6 weeks, may be safer for severe inflammation. Non-operative initial treatment. Nil by mouth, NPO, and intravenous fluids. Analgesics and broad-spectrum antibiotics. 3. Complicated cases. Severe or unresolved cases require CT imaging and immediate intervention. Severity grading, Tokyo Consensus Guidelines. 1. Grade I, mild no organ dysfunction, suitable for early laparoscopic surgery. 2. Grade 2, moderate features include WBC 18,000, palpable mass, or gangrenous pericholcystic inflammation. 3. Grade 3, severe organ system dysfunction, example cardiovascular, respiratory, renal. Additional notes. 1. Recurrent risk. Removing stones without the gallbladder often leads to recurrence due to persistent gallbladder dysfunction. 2. Prophylactic surgery considerations. Certain ethnic groups, example Native Americans, Northern India. Transplant and bariatric surgery candidates.